welcome members of the public and other individuals who have registered to join in our meeting today. As usual, the meeting will be recorded for the aid of producing the minutes later. If I could ask members of the public, the non-board members, to turn off cameras and turn off your microphones, please. It just makes managing the meeting for me much more straightforward as I look at my screen. And secondly, to remember that the text column is part of the meeting and is therefore for use by members of the board. I've received apologies for today's meeting from Aaron Cummins, from Talib Yassin, Roger Parr, Jackie Hanson and Andy Curran. This is the last meeting of this board in our current format. As I'm sure you're all aware, the Health and Care Act has received royal assent and comes into being with effect on the 1st of July. So at midnight on the 30th of June this year, our 8 clinical commissioning groups are succeeded by a single integrated care board for Lancashire and South Cumbria. Now, there's all these statutory changes and organisational issues that we've discussed here and that we continue to work through. But essentially, the Health and Care Act is about a legislative framework which supports collaborative and partnership working across the full spectrum of health and care delivery, with multiple partners outside of the healthcare sector, alongside health organisations, with local government, with other sectors coming together to work in collaboration and partnership to pursue our ambitions and priorities to improve health and care across Lancashire and South Cumbria. And I think that this board has been a great example of how we've been able to come together as a very broad system in that way and work collaboratively and in partnership over a number of years leading up to the formality of these changes. And I think that the leadership this board's provided and the inputs from each of every member, people who are here now, predecessors who were here at an earlier stage of the life of this board, have contributed immensely to the work, and which has had a significant impact on our patch and the populations that we serve. I'd like to make a particular mention to a number of members of the board. Firstly, I'd like to thank the non-executive members, Ian Cherry, Mike Wedgeworth and Isla Wilson. All 3 guys have been involved in this from the start, from well before when I started. They've made a very significant role in the meetings, but also have provided me, in the time I've been here, with great support and advice and guidance, both within the meetings and outside the meetings. And I thank Mike, Ian and Isla very much. I know that they'll all continue to contribute to the NHS beyond these changes, and I think that's great. I would also recognise the very significant work done by Andrew Bennett and the execs who've worked with this board over a period of time. It feels like yesterday, but it was last summer that Andrew stepped into the breach when Amanda moved to work at regional level. Andrew and the team, in very challenging times in terms of the demands being made on the service, the pandemic, the winter pressures, all of that, without any of the formal authorities that really come in with the new ICB structure in July, have provided very, very important and effective system-wide coordination and leadership. Again, I hope that that the majority of the team will continue to contribute to the NHS in different roles beyond 1st of July. I know for many that's already the case. There's one person, Gary Raphael, who's made the choice that this is the time to stand down and retire. So this isn't only Gary's last meeting of this board; it's one of his last days in post after a long and very, very impressive career in senior jobs across different parts of the North West. So on behalf of this board, I'd like to thank Gary for the immense contribution he's made. We wouldn't be where we are now without his work being central to everything that this board has achieved. And on behalf of this board, Gary, thank you, and I wish you very well in your retirement. This is, of course, now a time for transition for us, and at the same time, as we move on from this structure, the new IC board will meet for the first time on the first day of its existence on the 1st of July. The details of the meeting will be shared in due course. I have great pleasure in welcoming Kevin Lavery to this meeting as the new Chief Executive Officer for the Lancashire and South Cumbria ICB. Kevin will introduce himself and talk to the meeting shortly. Kevin's beginning now to populate the management and organisational structure of the ICB. Executive directors have been appointed. I'm going to certainly see that Sarah O'Brien's here in the meeting. Welcome, Sarah, today. And at the board, the new board now has the executive director post filled, the non-executive director post filled, and we're now going through the process to appoint partner members, 2 from NHS providers on the patch, 1 from primary care and 1 from local government. So certainly I hope that process will be complete by the middle of June, and we'll have a fully populated board ready to begin business on the 1st of July. So in organisational sense, this is the period, but in terms of the continuity of the work we have to do and the challenges we have to face, we continue to remain very focused on all of that, and the new organisations will pick up a fast start based on the work that's been done in this board and across our system through the CCGs and across the whole of our system with providers and local government colleagues and so on. So once again, thank you all very much for your commitment to and contributions to this meeting. Everybody's played an important role, and it is greatly appreciated, and I thank you on behalf of the system and of myself for all that you have done and continue to do in this space. Right. I've not been notified of any new declarations of interest or conflicts of interest. As always, please, if you feel in any point of discussion on any of the agenda items that there is a conflict you wish to make the board aware of, just please raise your hand and do that. We've our minutes of the meeting of the 2nd of March. Sorry. Okay, we are. We've made 2 small changes to the present list. Was here to represent Eileen Gibbies from Lancashire Teaching Hospital, so we've made that correction. Are there any other points of accuracy or clarification on the minutes that we need, please? Thank you. Can I propose that we adopt the minutes?
Formally second those, Chairman.
Thank you, Roy. In the action note of the meeting, the decision log, action and decision log, the third one of those around the new hospitals programme, we'll get an update today, but the detail of the shortlist and how that will be progressed, that work won't be completed until July. That was always the schedule, so we'll make that adjustment. So there we are, the formalities through. I'd like to welcome and hand over to Kevin Lavery, please.
Thank you, Chair. Good morning, everyone. And perhaps having just spent 9 years in New Zealand, coming back to Lancashire from New Zealand, I should say kia ora as well. I've been here for 60 days. I've spent a lot of time getting out and about, meeting staff across the patch, going to our trusts and our council partners and our voluntary sector partners too. And I guess I've been asking people, what does a great ICB look like? How do we measure up? Where are the gaps? And in the light of that, what, if anything, should we do differently? And I thought it would just be worth highlighting a few first impressions and then just putting on the table some of the issues that we're focusing on now. So three areas I think we need to look at doing differently going forward. Number one, we've got to give priority to strengthening the community health and care side of our system to balance the acute side. We should have the ambition to be a real standout performer in that space, and it will require in due course significant investment. And at the heart of that should be much deeper integration between health and care and getting much more of a handle on the determinants of health, which largely lie outside the NHS, and therefore the linkages with local government, with primary care and the voluntary sector are going to be really, really important going forward. Point number two, I'm really highly aware that the acute sector is going through one of the biggest crises in modern times, and as a result, performance is challenged within the system and the finances have been really stretched. Nevertheless, what struck me is there's lots of opportunities to do things faster, better, smarter. So, for example, we've got, and you're well aware of this, nearly 500 beds occupied by people who don't need to be in hospital. We've got overlapping clinical specialties. We've got an expensive and fragmented back office because for 30 years people have been doing their own thing. So there are lots and lots of things we can look at by working together to do better. And if we do that, we can address some of the underlying the sort of structural deficit, I guess, we've got on the acute side, but also provide some of that money to help fund the strengthening of community services going forward. And the observation number three would be, I think there are opportunities to improve the way we do things around here. It's partly about process and it's partly about culture. So absolutely moving to a collaborative culture and thinking about the whole system rather than just our little silo within the system. I tell a simple story of a man number one putting some bricks together, and you say, well, what do you do? He's saying, I'm putting some bricks, I'm laying some bricks. Man number two says, I'm building a wall, and man number three says, I'm building a cathedral. We need to be thinking like man number three about what our part is in that wider system. I think the second thing is process. We're still in the process now of signing off this year's budget, and it won't actually be signed off until next month. So it'd be a good idea if we signed off the budget before the financial year begins, so that we've got the whole financial year to go at for starters. And it would be a good idea, given some of the strategic changes that we're going to be looking at, to have probably a 10-year vision and a 3-year budget too, because all of these things are going to stretch between financial years. So I think that's something that's pretty important. And I think the third thing I would say is about the need for focus on delivery. I've worked in the public sector before. I know it's very difficult to really prioritize, but we do have a bewilderingly large number of strategies and priorities in the health service. And you know, I think one of the things we've got to do as an ICB is really focus on the things that are going to make a difference to the people of Lancashire and South Cumbria, and be clear what we're going to do first. So that's pretty important. And I thought it would be just good to highlight some of the key issues we're dealing with now. Number one, getting the new ICB set up right so that we get over the line on the 1st of July without falling over. The good news is I think all the constitution stuff has been sorted now, so we're in a pretty good position there. Number two is the transition of staff. We're not going to have everyone placed by the 1st of July. It's probably going to be the end of August, but we're progressing through that now, and we're talking to staff about those issues. Number three, the budget. We're facing a standstill budget across the system. It's going to be challenging, but actually we've got to move on from talking about it to actually delivering it. So, and have a sort of unwavering focus on delivery. And probably message number 4 for you is we are looking at the boundaries of the place-based partnerships. This isn't because we want to change boundaries for the sake of it. It's because if we want to do integration with local government, we have to make it easy for them to be part of it. If you look at Lancashire County Council now, they're in 5 partnerships. You try integrating 5 different ways, it's pretty challenging. So that's why we're looking at it. It's about the opportunity of deeper integration with local government. I've said enough, Chair, so I'm happy to stop there, and if people want to raise any issues, happy to answer any questions.
Thank you. Thank you, Kevin. Ian.
Yes, thank you, Kevin. Very interesting. On the 24th of December, we got the NHS plan for this year, and the first priority in the plan is workforce. You didn't mention that as part of your summary, but it's quite clear as a system we need to address the workforce issues, and that's going to take longer than 12 months to do that. So I just wondered what your thoughts were on the sort of workforce plan going forward. Look,
it's yeah, I agree with you, Ian. It's a big issue for us. We have very good retention, actually. There's a major recruitment challenge though in that space, and you're well aware of the huge amounts of money we spend on agency across the piece because we've got those challenges. What I've been encouraged by is we've got a lot of good HE institutions in our area that do target people from hard to reach communities. They come through and help meet our workforce requirements going forward, and they stay in the patch. So I think looking for ways to boost that more going forward is going to be really important. But I think we've got to stand back and say, actually, most of the workforce we're going to have in 10 years we have with us today. So part of the agenda has to be about reskilling and making, you know, getting people to adapt to the new requirements as we go forward. And digital is going to be a big issue there, isn't it? And I guess the other thing is about lots of the wicked problems we have to deal with. We've tended to have a very silo professional approach, and we need to broaden people out to have more generalist skills and be very adaptable going forward. So I think there's some of the things we need to look at. We've got a new people board that's going to be looking at these issues. I think we've got to give it high priority going forward, and it's probably a 10 to 15 year plan in reality. So it's that sort of time frame we need to be thinking about. But yeah, big issue, Ian, and good to meet you.
Thank you. If I could ask, one of the things that we've done, I think, very effectively in this board and in working outside of the board is and I've really welcomed, is the commitment from local government colleagues to working as partners in this way in the system, and it will be even more formally embedded in the new ways of working in the partnership, in the board, in the places. And I just wondered, in response to some of the points that Kevin's made, if Councillor Gooch or Denise or Neil wanted to say anything from their perspective on that, please. Graham.
Yes, I'm really looking forward to this. I've had the opportunity to meet Kevin and discuss these matters, and we really want to get involved in this. The coterminous boundaries are coming up as an agenda item later, and we can say more on it then, but that is absolutely wonderful to hear, because for all the reasons given, we've had so much difficulty working with 5 acute trusts, 9 and then 8 CCGs and all the other things. This gives us enormous opportunities to work more closely and talking about the same communities rather than across different borders. I'm looking very much at seeing working together on workforce, because we're both fighting over nurses. We need nurses for some of our nursing homes. The NHS obviously need them, but it's not working. So I think why shouldn't all the nurses still work for the NHS but work in our environments and give them experience of geriatric nursing and all that sort of thing. Similarly, we're fighting over occupational therapists, and we train more, NHS poaches them. It's nonsense. We're all doing the same job for the same community, and that's why we need together to work on this. And I think this new board gives us all these opportunities for doing that, and I'm looking forward to it enormously.
Thank you, Graham. Okay, I can't see anyone else wanting to come in at this point, so thank you, Kevin. Let's move on. Oh, Neil, sorry, Neil.
Oh no, well, I'd agree with Councillor Gooch there in terms of there's some really practical things that we can do together by making sure the integration really works, but also to make sure we're focusing on the right kind of community health and care as well. So moving resources out of hospitals into local communities and doing it jointly and doing it together could have a really massive impact in those areas with the worst health. So I think this is a really big opportunity for us all. We just have to commit to it. So take a few risks and look at it as a joint investment project. So we all put our resources on the table. That includes staff, that includes money, and we just have an open mind to doing things completely differently. And we're 100% on board with it.
That's great. Thank you very much, Neil. Now, one of the issues that has caused some of the biggest challenges for us to consider has been the managing of the resources. Item 5, Sam, the new Chief Finance Officer for the new ICB, will now tell us about where we finished at the end of year 21-22 and how it all looks. Thank you, Sam.
Thank you, Chair. So what we've got is a short paper here to provide a sort of a brief overview of the 21-22 financial outturn position. So we ended the year, and this is subject to our auditors all being in at the moment, but so far I'm not hearing anything to the contrary about in terms of what I'm going to tell you now. But we ended the year with a 13 million deficit, but this was in line with an agreed national position. So that 13 million is actually relates to a technical allowable deficit, which I'll come on to in a moment, which actually means that all organisations met their plan and achieved their outturn, which is a brilliant position, and well done to everybody for achieving that. So as a system, we delivered against the plan position across every individual provider with a £600,000 surplus, and CCGs were allowed to include an adjustment. And this adjustment was for prepayment for medicines supplied in advance that were entered into the CCG books in 1920 to give a one-off benefit. But it's been identified as an unadjusted error on subsequent audit reports since that time. And so from a technical perspective, the auditors didn't agree with that treatment. So NHSE asked CCGs to eliminate any unadjusted errors by removing the prepayment and allowing it therefore to be taken forward as a clean position for the new ICS as we establish the new statutory body. And it also protects what is around 10 million of resource going forward and doesn't impact on the underlying position brought forward from CCGs into the ICS. And although it was agreed by NHSEA and actually asked for it to be treated in this way, it wasn't cash back. So that's why it appears as an allowable deficit. The action does actually lead to a qualified audit regulatory opinion, but not qualified accounts, and there is a distinction. So what they're in effect doing, NHSE, is they're agreeing that this is an exceptional item, a one-off technical adjustment. So other than the 13 million position, it's a balanced position. It's for the greater good, and I guess it's with written confirmation that it's not viewed as a financial failing. But obviously, this has been difficult for CCGs. The audit chairs, CFOs, audit committees have spent some time looking at how we manage this through the books, and that was agreed that, you know, for the greater good and moving forward with a clean slate, that would be the position. So that's the overarching position, and in doing that, the whole system delivered 125 million of efficiencies, and cash has remained strong. And in fact, although I've not included cash in the paper, the cash balance sort of increased during the year by 43 million. So, you know, we are entering in with a fairly strong cash balance. And finally, capital came in on plan, and this is always difficult. We always have slippage in year, and I think there's been a lot of work between organisations and through a capital oversight group to manage that slippage in schemes and make sure that we don't lose this, because we're given a limit every year of around 110 million it is going forward. But it's really good achievement that we came in so close, because it means we don't lose that opportunity to spend capital within that limit. So I guess it's been a really, really challenging year to deliver. When we set out at the start of, I suppose we had two starts, we had H1 and then we had H2, so 2 halves of the year were planned for. But certainly as I came in during the beginning of this at H2, I think people were facing a very challenging position this year. So people have worked extremely hard to achieve this year-end position of being, you know, a balanced plan. And the position in 22-23, it gives us a good position to start from going forward. We know there are challenges going forward, but I think it signifies good progress. So I'd like to thank everybody on this board and all organisations that have put that effort and that work in to make that possible. Happy to take any questions.
Well done, Sam. Roy.
Thanks, Sam. Thanks for that. Thanks for the paper and your comments there. We had I'll speak now as a CCG chair, and we had a board meeting yesterday, and I have to say that I expressed my extreme disappointment at having to deal with the technical deficit. Although, as you've rightly explained, that's been dealt with in a really good way, I think, by the CCGs, and going forward. Again, as you've commented, that we are not leaving a deficit with the ICB as a result of that. So I think that's a good result ultimately. However, I do have to say that clearly, as you've inferred, that our external auditors see this as an issue for the CCGs, and will have to be reported to our accounts and our annual report. I think that we're looking at the wording that we've put in our annual report with regards to that. You know, we've met all our regulatory and fiduciary duties over the last 8 or 9 years of the CCGs, and I think this is a really disappointing end. So, you know, I accept the position, absolutely accept the position, but I do have to express my disappointment at why we've had to be put into this position in the first place. Thanks, Sam, for your comments.
Thank you, Roy. I'll share your disappointment. Any other comments on Sam's report? Ian.
I wasn't going to comment, but I feel I should do as audit chair of Central Lancashire, Greater Preston. I mean, this was a mandated decision. We could have balanced our books if we wanted to, and I think that's important to make that point, because we could have used our CHC reserves to balance our books. But we were mandated to make this particular deficit. So I think it's just useful to put on record that it's not a mismanagement in any way. And the reason for doing this is really quite simple, that unadjusted error becomes material when you're doing the 3-month accounts. So all of our 3-month accounts would have been qualified if we hadn't have dealt with this error in this particular time. So it has a knock-on effect, and it also leaves a clean bill of health for the CCGs transitioning into the ICB.
Thanks, Ian. And Kevin?
Thanks, David. And just on a positive note, I think we do need to recognise that this is a tremendous systems effort to get to the position that we've got to, and it's combined all our organisations, both CCGs and providers, working together, and I think in a really mature way to land the finances as we have. So I think we should, recognise the good stuff that's going on, but also give a lot of thanks to our finance colleagues, because this has been a really difficult year being a finance professional, and being able to land it the way we've done, with the technical issues notwithstanding, I think deserves a lot of credit to the finance profession and everybody across Lancs and South Cumbria for getting into this place.
Agreed, Kevin. Thank you. Right, that's good. Let's move on. Our next item is Vanessa's here to talk to us about the Ockenden Maternity Review Report. Members who've been on the board a while will remember we received an update and had a discussion on an interim report over a year ago. The final report was produced in March and has a number of significant recommendations for the NHS, all parts of the NHS. You will remember Donna Ockenden was asked to do this work after issues emerged in maternity services in Shropshire. So Vanessa, over to you, please.
Thanks very much, Chair. Sarah, I don't know if you wanted to say anything before I kick off.
So why don't you do your present the paper, and then I'll comment at the end, if that's okay with the Chair.
Yeah, if it's all right, Chair, I've done just a brief presentation to take the members through. You're okay for me to share that?
Yeah, good. Yeah, good.
Can everybody see that? Yes.
Yes.
Yeah, we can, Vanessa.
Great. So for those that don't know me, I'm Vanessa Wilson. I'm the Programme Director for Women and Children's Services for the ICS, soon to be ICB, and also the SRO for Lancs and South Cumbria Local Maternity and Newborn System. So I've done a brief presentation. Some of this Chair's just outlined to you. So obviously this is as a result of concerns about maternity services at Shrewsbury and Telford hospitals. Involved a huge amount of families, a total of 1,592 clinical incidents. The vast majority of these incidents between 2000 and 2019. And as we've just been reminded, there was an interim report that was published in December because there was the findings were found to be too serious to wait for completion of the investigation. And then we've had the final report just in March this year. So the interim report from 2020 had 7 immediate and essential actions for all maternity providers. So there were some recommendations that were just for Shrewsbury and Telford, and there were 7 that were for all maternity services. And these are listed on the screen in front of you. I'm not going to go into all of them in detail, but in the course of the last 12 months then, before the final report has published, there's been a lot of work undertaken by the system, by all our maternity providers across Lancs and South Cumbria. So there was a huge exercise done in terms of a gap analysis against the essential and immediate actions, and a massive exercise in terms of evidence submission to the regional and national team to evidence where everybody was at in terms of being compliant with those they're not recommendations, they're essential and immediate actions. All providers were then required to take a paper to their public board by April this year to state where they are against those 7 recommendations. There are also recommendations in the Ockenden reports for us as a system. It's not all about the maternity providers. There are recommendations for us as a system that we've had to put in place over the last 12 months in terms of establishing our maternity quality assurance panel. on behalf of the ICS. So that's around the mandatory quality surveillance moving from, well, as it is now in the CCGs, to the ICB. And we've had that running in a shadow format for the last 8 or 9 months, led by one of the NEDs from Lancs Teaching Hospital. We've also started and have done 2 out of 4 insight visits to our 4 providers, along with the regional team. So that's myself and Steph Purcell, who's the maternity quality performance manager, have joined the regional team, and the NVP chairs, maternity partnership chairs, to visit each of the units. And as I say, we've done 2 out of the 4 so far. So in the trust papers that were presented to their public boards earlier this year, you can see on the screen what each of the trusts were declaring themselves as. And I think that the thing to say is the purple line at the bottom, which the fact that some of them are saying that they're not fully compliant with all 7 IEAs is not a cause for significant concern. Each of the IEAs is not a simple statement. Each of the IEAs has got about 15 or 20 actions underneath them, and some of them relate, one action can relate to more or 1, 2, 3 or 4 IEAs. So the fact that they're not fully compliant possibly means that they're just missing 2 or 3 actions out of 20, and they're not significant things that are missing. They're just being really robust in terms of not saying they are compliant until they are absolutely fully compliant. So the top 3, Lancs Teaching, East Lancs and Blackpool, are well on their way in terms of delivering all of the 7 IEAs. Obviously, board will be aware around the issues at Morecambe Bay relating to their maternity services, in terms of them having the national support team in following their CQC inspection last summer. So they are at the moment revalidating all their evidence around this and around a number of other areas around maternity, but they are well on with it. And board will also be aware that they've been really successful in terms of recruiting a really fantastic senior maternity team, midwifery team at Morecambe Bay in the last few months that was lacking. So they now have a director of midwifery in post, a consultant midwife on their way, and 2 heads of midwifery. So a really strong team now at Morecambe Bay that I'm sure will be moving this on now at a pace. And as I've said, the ICB and the LMNS, as the maternity arm of the ICB, have met the elements of the essential and immediate actions required as part of the work that we've done as a system. Just a couple of the themes, just to point out what some of the areas are that people are possibly not compliant on at the moment. So staff training and working together. During the pandemic and due to the workforce pressures, etc., attaining and sustaining the 90% target has been very challenging. There was a period of time when face-to-face training was stood down, but they are now all back on track with plans in place to catch up with that training, and face-to-face training is now reinstated. Workforce planning, recruitment and retention. There was a requirement within the Ockenden Interim Report that all providers needed to engage with the birth rate plus workforce tool for midwifery. As you can imagine, every maternity service in the country needed to engage with birth rate plus, so there was quite a waiting list in terms of getting that piece of work done. All of our trusts have now had the assessment done for birth rate plus. We're just waiting for East Lancs report to come in, which is imminent any time. So that again just delayed things being signed off. We're also waiting for the publication of the workforce tool for obstetricians from the Royal College of Obstetrics and Gynecology. And a number of trusts have got business cases in train around the recruitment of outstanding midwives, consultant midwives, and to achieve safe staffing. Complex pregnancies is also an area where the 4 providers are not quite where they need to be, but that's on down to the fact that we are currently developing a Northwest maternal medicine network. So there will be 3 sites as maternal medicine hubs, and one of those will be. At the moment, there's a clinical reference group working through the pathways, and we're on with recruitment to some of the network back office team. But there is a significant amount of work, but it's not at the point where people would say they were compliant with the requirements as yet. So just briefly about the final report, this was published on the 30th of March 2022. It documents 60 actions for Shrewsbury and Telford, and a further 15 immediate and essential actions for all maternity providers. And within those 15 IEAs, there's over 90 individual actions for maternity providers to meet. Many of the items in the report build on the initial 7 IEAs, but there's a further emphasis on the areas shown on the slide. So a further emphasis around safe staffing, numbers and training. And that's not just midwives. There's a whole chapter in the report about obstetric anaesthetists and making sure that we've got sufficient and with sufficient training. Neonatal care is pulled out in the final report more than it was in the interim. Shrewsbury and Telford were working way out of their licence in terms of neonatal care. They'd been reinstated and downgraded as a local neonatal unit some time ago, but were continuing to work as an intensive care unit. Other failings in terms of listening to people, listening to women, listening to staff, and the other things that are there for you to read and in the paper that we all have seen previously. So in terms of the next steps, we will complete the Ockenden site visits, the in-site visits with the regional team. We have requested the gap analysis to be completed by each of our maternity providers against the final report to come to the LMS board for July. That isn't a request at regional or national level as yet. First look at where we've got any gaps against those failings and where we might be able to progress things at a system level to provide support to our providers. And a proposal that we've come back to board in September, Chair, if that's okay. There will be a further publication in September of a report from the investigation into East Kent maternity services. And following that, there'll be a new national maternity delivery framework. So I think it would be timely for us to come back to board in September. Thank you very much. Happy to take any questions.
Thank you very much, Vanessa. Sarah, anything you wish to add?
Thank you, Chair. Thank you, Vanessa. Just a few comments really from me coming new into the ICB Chief Nursing Officer role. The first thing I would say, if anybody hasn't read the Ockenden report that was published in March, it is a very long document. I think it took me about 6 hours in total to read it, but I would highly recommend that anybody who's a member of any board in the NHS needs to read that report. It's sobering reading. I was in a senior nursing role in an acute trust when the Mid Staffordshire report came out, and unfortunately and disappointingly there are elements of the Ockenden report that take me right back to that Mid Staffordshire report. So even though we've done a lot of work to address patient safety, to address culture and leadership, I think at the heart of the issues at Shrewsbury and Telford was poor culture, poor leadership and poor practice. So it's just a stark reminder that if we don't stay on the top of our game in any NHS organisation or whichever role we play, that unfortunately the impact is devastating. And for the number of families that have been impacted by the poor practice at Shrewsbury and Telford is very sobering. So everybody needs to read it really just to remind ourselves. What I would say there was first few weeks in post, a bit like Kevin, I've tried to meet as many people as I can, including the directors of nursing in our providers and Vanessa and her team. And I do think we've got some robust processes in place, the work that the LMS are doing, the work that the directors of nursing are doing in the trust. So I would reinforce everything that Vanessa has said, that we are reviewing the Ockenden report, robust action plans are being put in place. I think our response is robust. I've met with the regional team who also haven't flagged up any issues in their concerns that Lancashire and South Cumbria will be able to respond to Ockenden. So I think that's really reassuring. However, given the challenges that we've got that Kevin has placed, you know, it is important that all of our NHS boards and the ICB board do keep the need to respond to Ockenden and implement those essential actions as a key priority for us. I know there's lots of priorities, but this really has to be a must do. And I envisage, as well as reports coming back to board, Chair, that the Quality Committee of the ICB will also keep an oversight of progress against the Ockenden essential actions once we've got that committee up and running. So that's all I wanted to say this morning.
Thank you, Sarah. Can I just ask Kevin and Martin and Trish and Chris, who's here for Aaron, just to give us a quick flavour of where each of the trusts is up to now, please. Kevin, do you want to go first?
Thanks, David. And to give assurance, I'm sure all my colleagues will say, the individual boards have taken Ockenden incredibly serious and have spent a lot of time both at full board level and in subcommittee level in terms of ensuring that we understand the Ockenden recommendations and we're moving forward at the implementation of the Ockenden recommendations. So it is an absolute priority for our organisations. I would also say that we have some really outstanding maternity services across Lancs and South Cumbria, and that's not said in any type of glib way. It's based on real sort of benchmarking data in terms of performance and how good those services are. But there will be challenges, particularly around staffing. And I think we do need to be careful in terms of the staffing levels, because what I don't want us to get into is a bidding war between organisations in terms of trying to either pinch staff for one another or raising the costs of the services unnecessarily. So Vanessa, I know you're doing this, but I think there is a piece of work that we do need to coordinate across all of our organisations in terms of how we react to Ockenden and the safe staffing levels, and do that in a mature way, in a way that supports all of the services and doesn't leave anybody behind.
We are, just to come in on that briefly, Kevin, we are starting conversations about system level recruitment for midwifery, particularly because we're conscious at the moment that, well, I know from my visits that various trusts think they've recruited sort of 20 or 25 midwives for September, just a bit anxious that they all think they've recruited the same 25 midwives. Yeah. We are going to start some of that system level recruitment.
Great, and it's a really and where we absolutely need to work together as a system through provider collaboration to ensure we've got consistent delivery across all of our services. And then the only other comment I would make, David, is we need to do quite a lot of work, don't we, Vanessa, in terms of neonatal services going forward and the level of neonatal services and the units across Lancashire and South Cumbria. And again, there's going to be some challenges to us in terms of the number of the number of births and the number of children that go into those neonatal units, and it may require some degree of reconfiguration. And again, we've got to do that together and in a way that's mature and gets the best outcome from our patients and takes organisational sovereignty off the table.
Yeah.
Thank you, Kevin. Trish, please.
Thanks. Just a couple of things to say. So just for assurance, the Ockenden report and our actions and response have gone to our board. But I think my own reflections on this is, and Sarah quite rightly says, the report itself does need to be read by everyone, but it is in depth and complex at times. And the complexities can be quite difficult at board, particularly for those that don't work in maternity services. But I think what the last conversation we had on board around this is, the importance is, let's keep it as simple as we can. Number one, maternity services are probably one of the highest risk services that any NHS organisation probably manage, and should be treated with that respect. They are high risk to us all. So the need for visibility, openness, and for boards to be curious on this matter is paramount. In addition to Ockenden, because it is fairly complex in terms of some of the actions required, we've been discussing as a board that we have put some simple metrics around outcomes, expected outcomes, into our integrated performance reports moving forward now, and engagement. That is absolutely crucial. So engagement there, that we've got the actual maternity team twice a year coming to our board to talk to us directly, and also ensuring that those stories from families come up. And I think, to me, we can have the conversations about staffing, and Kevin is quite right, as a system we need to go together with this. But my experience is, this isn't just about staffing and numbers. You can have as many staff as you want, but if you don't get this culture right in terms of curious behaviours, and also to be able to challenge each other and to do that in a respectful way. So that's the bit that we're really concentrating on as an organisation here. We've got non-executive directors as champions as well, because again, having more than one set of eyes on this is going to be crucial moving forward, and we will continue to be very open to welcoming other organisations across our place-based in to give us that check and challenge, because I think that's key moving forward.
Thanks, Trish. I'll just go to Martin and Chris, and then I'll open up. Graham, I'll come back to you. Martin, please.
Thanks, Chair. Yeah, very similar. Just to confirm that both progress around the interim report and the final report has been through our board. It is actually a standing agenda item on our quality committee and has been for some time. So a bit like Trish, a lot of assurance evidence is going through the quality committee. I guess a couple of things really. It's made us really look at the relationship of the sort of board to the floor, you know, the floor to board. So like Trish said, we've got a non-executive maternity safety champion, Mike Wedgworth, who's a member of this board. But, you know, that visibility, safety walk-rounds, etc., the cultural bit that, you know, has been mentioned by Sarah. One area I think of good practice that Vanessa will be aware of, we've used SharePoint as a tool to collect all our evidence, and in the regional visit, and also we've had a visit from Jacqueline Dunkley Smith, I think Smith Bent is it?
Bent, yeah.
The Chief Midwifery Officer for NHS England, and she was really blown away by that assurance, you know, tool that we use, and it's good for things like CQC as well in terms of providing that evidence. So I think, you know, good progress. It as Sarah said, it's made us look at all services though, because there's some specifics for maternity, but there's a lot of generic stuff for all clinical services. That compassion, how we engage with patient and families. So as a board, we've taken stock on that too, just about all clinical services and how we interact with our population that we serve. Thanks, David.
Thanks, Martin. And finally, Chris Adcock, anything to add?
Well, very specifically, I won't repeat things other people have covered, but there is a reference in the paper to the current position showing Morecambe Bay as amber against the various criteria. We do reassess ourselves monthly, and in May we will be able to report that we've moved from a position of overall partial compliance following testing and evidence and the position with support from the regional midwife. You'll also be aware that we have a specific maternity focus, and we take a maternity safety report to our board every month, and we're supported in this through the recovery support program. So we do still have 4 areas with partial compliance. There are clear actions in place and timelines associated with that. We have now appointed, and she's a director of midwifery, and she's now taken up her post, and she's providing oversight regarding all of that. So, and we're going through a review with members of the national team to undertake an on-site assessment of our position on this.
Thanks, Chris. Graham, please then, Jeff.
Yeah, I was just wondering, is the scope to do more in the community to adjust lifestyles and behaviour that may prejudice a successful pregnancy, so that some of the complications that lead to difficulties when it comes to actual maternity delivery can be avoided? Is there more we can do in the community?
Sarah, do you want to come?
Do you want me to come in, Sarah? Or?
I don't mind. I'll comment first, then you, Vanessa. I mean, it's a really excellent point. So, you know, I think the whole population health agenda. So if you think of things like type 2 diabetes, which presents as a very high risk pregnancy, then a lot of the work that we would want to do for population health and prevention programs to prevent type 2 diabetes, for instance, in the first place, would help in the way you said. Although I do think the issues that come out in the report are very specific to how pregnancy is managed then once they get into an acute trust. But it's a valid point, and it's all interlinked. Vanessa may want to add further to that.
Yeah, just to say that we do have a whole arm of the work from the LMS, which is around prevention, which is working on sort of, you know, smoking in pregnancy, infant feeding, healthy weights, all that sort of side of, you know, preconception care for particular groups of women, and a lot of work at the moment looking at equity and equality around access to services because of the report through Embrace in terms of the poor outcomes for people from disadvantaged communities or Black and minority ethnic communities. So we're at the moment doing an action plan around that has to be submitted in September, but that's very much around that community input and supporting them, before the pregnancy. Yeah.
Thank you. Anything we can do to help, let us know.
Yeah, we're very linked in with the local authorities on the prevention side of things particularly, but certainly we will shout if there's more that we can do in partnership. Thank you.
And Jeff?
Thanks, Chair. In answering that last question, I want to just give a very quick answer and say excellent antenatal care is going to result in better outcomes, but it's not going to solve all the problems that Ockendon's picked up. And a good example there that we could have done a lot better in the pandemic is a uniform vaccination rate amongst pregnant women, and we failed there, and that's so that's an example of how inequalities have played out in that area. So it's an example of where Graham is right, but it doesn't solve the whole problem. But I want to talk about Ockendon. I'll raise to Sarah's challenge, and I will complete to read that report, but it's a big one, so I haven't finished it yet, I'll be honest. And so shame on me, but I will get there. I was in Morecambe Bay before the Morecambe Bay crisis, and I was subsequently part of the Kirkup review, and then I was for Cumbria CCG on the board that oversaw it putting all the problems right, and it was very successful. And I've got every confidence, as Chris has alluded to, in Morecambe Bay actually really performing excellently. I don't think any of the trusts will fail to perform excellently across what needs to be done. The issue for me will be, and this has played out a bit in Morecambe Bay again, and will play out everywhere, is how you maintain standards. So, and I don't expect an answer today, but the answer I'm looking for is how we're going to do that, and not the sort of final assurance that yeah, we're there. So we have to go through this process of resolving all the issues in all the trusts and being assured that we're now safe and effective, etc. But I just wonder what role we're expecting to either the provider collaborative or the ICS itself to ensure that things don't slip again, because slip as sure as day follows night, they will. And you know that's been my experience in both maternity and in other issues. Unless you've got your foot on the gas all the time, and as you've said, this is the most high risk of services, we should put a particular emphasis and priority on making sure year in, year out, all our maternity services continue to be safe. So I just wonder how it's going to play out once we've got through this period of solving our current issues. Thanks.
Thanks, Jeff. It's a good challenge, Vanessa.
Yeah, I think and it's not the complete answer, but I think part of that is around what we've done in terms of the requirement now for it to be led at a system level. So it was too remote, some of the monitoring and the assurance, and I think it was too remote or too fragmented. So now we have a quality assurance panel for Lancashire and South Cumbria as part of the ICB specifically for maternity and newborn services. We have a dedicated quality and performance manager as part of that, who is looking at the data day in, day out, who will now, thankfully, be able to go into organisations and meet with people. That's been one of the great things about the 2 visits we've done in the last couple of weeks around the insight visits, actually getting on site and talking to staff and talking to women and families, etc., about their experience, which, I mean, like you say, you can see all sorts of things on paper. You learn an awful lot more by talking to people. So that's been invaluable. And I think that's consistency around that, and that looking at it as all four providers, but equally we work very closely as the maternity services across the northwest coast. So we're also, our dashboard is shared with Cheshire and Mersey, so we have opportunities to benchmark ourselves further afield in terms of not just our 4 trusts, but how does that compare with other maternity providers in the northwest. So I think there are more robust processes in place. We just need to make sure that they work properly for us, and we've really got our eye on what's going on and building the relationships, or continuing to build the relationships with the provider trusts that we already have. I think we've come an awful long way with maternity since the beginning of the LMNS in 2017 in terms of really feeling that we're working as a maternity system. I think we're seen as a very strong LMNS by the regional team, etc. Because we have created those, that open culture and transparency. So the 4 units talk to each other all the time. I talk to them all the time. Seth talks to them all the time. So it is a good. We're in a good place, I think, Jeff. I'm sure there's more to be done.
Trish, then Sarah, I'll ask you to anything you want to say by way of conclusion before I move on.
It was just to come back on that question, and I don't mean this to sound as simplistic as it maybe would, but I think there's two things as providers, both as individual providers and as a collaborative, that we can do that are quite simple and are not involving cost. Number one is creating boards where a culture is set, where it's recognised that things do go wrong, that we encourage staff to call it out, and that our focus is more on the learning and the moving forward. And I think that's really important. And I think, again, that's a theme that goes right the way through that Ockenden report. And then the second thing as provider collaboratives is that we actually offer regular peer review. Going back to that thing about being a critical friend, it's about not being defensive, but it's about going in and seeing things through fresh eyes. And I think that's something we could do quite quickly and simply, whereby it's not additional resource, it's moving our resource about. So I think they would be two key things. But I think as an organisation, I'll just speak as a chief exec. That's my job, to create that environment where people do call it out, and when things do go wrong, that we listen to people and we don't get defensive, because when we do get it wrong, often the only thing we can offer families is honesty and truth. So I don't think that's an awful lot to ask of a board. So that's got to be the key for us.
Thank you, Patricia. Completely agree. So Sarah, in terms of how we go forward, and to use Jeff's phrase, keep our foot on the gas on all of this, how do you see that working?
Yeah, so thanks, Chair. And I would have made the 2 points that Vanessa and Trish have made in terms of sustainability. I actually think the most important thing is that culture within the organisation, and that is down to the chief execs of each of our provider trusts. And then the second part is what Vanessa explained, it's having a clear oversight as a system. And I think this is a good example of, we've already got the LMNS, as Vanessa's described, where we do a lot of that oversight, but now moving to an ICB where we've got then one overarching board for the system, which the LMNS will feed into. And in my role as chief nurse for that, I'll have that ICB level exec responsibility for all of this. I think that will help us keep that kind of oversight and that assurance as a whole system, while our providers are continuing to do the key bit they need to do. So I think going forward, Chair, it will be as an ICB, I'll have exec leadership for this area. There will be a clear lead role within my portfolio for this area, and then that person will work closely with all of our organisations, a bit like we're doing now, but the oversight will come through the Quality Committee, the ICB, feeding into the ICB.
Thank you, Sarah, and thank you very much, Vanessa, for coming along and for your excellent presentation.
Thank you.
Appreciate it. Right, let's move on. The System Reform Programme update. We're getting close to the 1st of July now. Andrew, update, please.
Thanks, Chair. Yes, so this report is something you're familiar with in this board, but obviously this is the final report we're bringing to the ICS Board in its current form. And as you can see, it reflects, again, this sort of extensive work which has been taking place under this programme. Thanks already been expressed to colleagues for some of the work they've done. I want to repeat that, particularly for this work. A number of colleagues contributing to this paper, and that reflects, again, the breadth of the work streams that we've been planning and running through over the last 18 months or so. Some obvious points that really build on your early introduction, David. There is now very much this sort of drive to get to the point where by the 1st of July we have an ICB becoming a statutory organisation. So lots of work to finish off the constitution and governance arrangements, the appointment of partner members, and we've referred to that in the paper. We're using a readiness to operate process, which of course is happening through our national and regional colleagues, and clearly now, as Kevin's comments earlier indicate, the designate ICB execs are playing their full role in leading this process now through to the 1st of July. So that is very much in play. Just to complete the introduction, just 3 points of emphasis I thought today, drawing your attention to section 5 in the paper, where our oversight group has reviewed 2 very significant pieces of work that we were required to develop around our approach to working with people and communities. So Neil Greaves, credit to him for leading some thinking both from an ICS perspective, so across the whole partnership, how we approach that together, and then specifically how the ICB will develop its approach to people and communities. And there's a range of principles in there and different approaches that build on the way that we've worked. And perhaps in that Ockenden example we just talked about, a number of you were mentioning the particular importance of working with mothers and families at different stages there. So there's quite a bit to go out there that the ICB will come back to. Second point of emphasis, obviously now CCG is preparing for the close down process. We are preparing legacy documents. We are very mindful of risks at this point of transfer, and Kevin Lavery in his earlier comments again mentioning the fact that he is now leading the briefings for CCG and CSU staff who have uncertainties about the future, but we believe also have some very important roles to fulfill going forwards. And finally, in section 10 on slide 30 in your pack, Kevin's already referred to the review that he has commissioned of the boundaries of our place partnership. So that is underway. Jane Scattergood, who's well known here, has been leading that, and she's currently going through the process of meeting colleagues across the system to understand the issues that review raises for them. So again, her report, that report, as you can see, will come back to the ICB during its early weeks of operation. So the paper hopefully is clear. I'm happy to take any further questions, but thank you at this stage.
Thank you, Andrew. It is very clear indeed. Any points of clarification sought from members of this board, please? Martin.
Thanks, David. Yeah, it's just that issue of, we've got a lot of good people in the system, and, the size of the challenge this financial year is huge. So it's just through that process that we ensure we keep that expertise in the system. A lot of good people in CCGs that I'm sure we can use their expertise in all sorts of things, really. So I know there's an HR process, but it's just through Kevin's briefings, etc., that we keep that expertise.
Thank you, Martin. Anybody else? Neil Greaves, if Neil's on, I'm very impressed with this work on communication and engagement. Is there anything that you would like to say about next steps on that?
Yeah, so it's what we've been developing over the last number of weeks is really joined up approaches of how we want to work in the future, really valuing some of the work of our partners in that space around how we engage and work with people and communities. Some good developed links of some of the best work that we do across local authorities and the voluntary community and faith sector. I think it's definitely going to be a real focus for the ICB going forward about how do we really maximise the way that we want to work with people in the right way. The work on co-production, we've had Health Watch as part of this group who've been really championing some of that and have been involved in this as well. So nothing more I want to say really other than we've done some really good work that's been co-developed. I think it's now about how do we develop some of our ways of working and around some of the priorities that we're going to have as an ICB to really demonstrate and use that as a kind of lived examples of actually involving people in the way that we want to going forward. But thanks massively to other people who've been on this call who've been involved in some of that. So our voluntary sector partners, people who are working on patient experience in some of our trusts, local authority engagement colleagues as well, who've been actively involved in some of the development of that work. And it's building on the best work that we've done, I think.
Well done, Neil. Angela.
Yeah, I just wanted to reaffirm, I think I've mentioned it at a couple of these meetings recently. It's great to see that the BCFSE sector is such an integral and important part of the whole system reform. Kevin talked about it in his opening discussion. Obviously, David, you've referred to us, and we're very much a part of the new comms plan as well. So it's just to say from a sector perspective that it's been a long time coming, I think, in getting a place around the table that is both justified that we make the most of, but is also respected by our partners across all of the sectors. So as Neil said, we've been very much a part of this new plan, and we look forward to continuing that relationship.
Thanks, Angela. Thanks for saying that. I'll just skip the order, Roy, for continuity and go to Tracy.
Thank you. Sorry, Roy, to pip you at the post there. Yeah, just to follow on really from what Angela said, absolutely. Really great developments. I really feel that it's gaining momentum now in terms of the positioning of the VCFSE in particular within the system. But I just wanted to remind colleagues that there's a big piece of work happening in the background around cohort 3 that both myself and Angela have been heavily involved in. And the culmination of that work is due to report back fairly soon around some recommendations as to how we create some of those structures across the voluntary sector, and making recommendations to the ICB as to how some of that is resourced. So that's happening in the background. We will be coming back with those in due course to really kind of set out our stall from all of that work as to how we take this forward and make sure that we continue with the good work that Neil's been doing and everything that's been going on across the voluntary community, faith and social enterprise sector.
Thanks, Tracy. And again, thank you very much for saying that in this meeting. Greatly appreciated. Roy.
Thank you, David. And just following on from your earlier comments about thanking people for the work that they've carried out during the board, I'd like to specifically thank Dennis Gitsy for being the SRO of the closed down process for the CCGs and the team behind Dennis. I think there's a huge amount of work that's been done. Some of it's reflected in that paper. There is now only one red rag risk within that now on the risk register, and that is regarding staffing. I think we have indicated our concerns about the staffing issues earlier on in this meeting. But as I say, huge amount of work that's gone on, and I would ask the board, actually, Chairman, to join with me in our thanks to the people who've worked on that, and this is the opportunity to do that. Thank you.
Thanks very much, Roy. Very well said, and thank you, Dennis and colleagues. Also, immense amount of work and ground that you've covered on all of this. Right, Andrew, thank you very much indeed.
Thank you.
Well done. Item 8, net zero carbon strategy. Alistair and Gary. I don't know who's going first.
Thank you, David. I'm just going to kick it off. So, as if the NHS didn't have enough to do, there is a massive agenda that's associated with achieving net carbon neutral status in 2045, and some really key targets to hit across then. So we're at the very early stages of development of strategy and policy on this, and I hope that the way the paper's written gives colleagues on the call, and if the paper's shared more widely, a sense of some of the big numbers that we've got to hit over a period of time, and hopefully describes it in a way that you find informative. And we've also put into this cover report some snippets from the work that's already been undertaken in trusts. Our trusts are already on the agenda for this, but there is a requirement for this to become a system-wide process, and it needs to be, because it's such a big strategic issue. So first of all, I hope you found the report informative. I've just got 3 more short points, and then I'll ask Alistair just to finish off. So the paper isn't committing the ICS or the ICB to anything substantial at this stage, other than to acknowledge its importance, and it is going to have to keep coming back to the board for regular updates, and to nominate an executive lead for the ICB once the ICB comes into being. That is a requirement of the net carbon zero requirements that we have on us. So that's really all the report is doing at the moment. But the other aspect of the report is intended to accompany and to shape the submission of a strategy document. Now, Alistair Rose has put together a strategy document. It's currently about, I'm not sure, it's about 80 pages. and we didn't think it's appropriate to bring that to the ICS board. But what we're hoping is that if the members of the ICS board, of which there are colleagues who will be going forwards into the ICB, feel that the broad shape of this is about right for us at this stage, then Alistair can just use it to reshape and refine a final version of the strategy and get it submitted to NHS EI. We're a bit late with the submission, and that's why the report's coming to the ICB, the ICS board, rather than waiting until the ICB. And we felt we needed to get it out the way and not have the ICB having to sort this out. We felt it was at this early stage, it will be possible for the ICS board to support this. So assuming the ICS board is content with the report, as I said, Alistair will use it to accompany the submission and get that into NHS EI. And the final point is, I think at this stage, it's really about making sure that NHS EI are apprised of the fact that we are aware of the size of the challenge, that we're aware of the issues, and that we're going to accord it the importance that it's going to need over a strategic time frame. And as we've written in the report, managers and other leaders will come and go over the period between now and 2045, and the green baton will need to be handed on to the next management team, and we need to keep this going. So that is something that is quite important to appreciate. And if you like, going from the ICS board to the ICB feels like the sort of first stage in that process, and it's something that we'll probably have to get used to in Lancashire and South Cumbria. So the recommendations are hopefully simple recommendations that are easily supported. I just wanted to check, Alistair, is there anything you wanted to come into just to emphasise that I've missed in this brief introduction to the report?
Just a couple of points, if I may, Gary. So we're at a similar place to.
Are you on mute, Alistair?
Am I? Am I not on this? Can you hear me?
I can hear you, Alistair. I can hear you.
You can, good. Everyone is at a similar place with this. The NHS has committed to be at net zero carbon at various increments. There's an 8-year increment, there's an increment at 2040, and then there's net zero carbon plus. The plus bit is our partners and suppliers and those things too. What we do need to do is consider an ongoing steps to move towards net zero carbon, and this will affect most things we do at a citizen level, how we travel to work, those sorts of things. But where we plan our services, rather than moving patients across a county to a hospital, bringing care closer to home, all these things will reduce the carbon footprint that we do, and it will affect service planning, service delivery, but also the condition of our estate. The hospitals are underway at the moment reviewing everything that needs to happen per hospital site across Lancashire and South Cumbria to get to net zero carbon. That work's underway. We should see the results of that during this year, and we can feed that back in nationally, because it will cost money. It will cost nationally a lot of money, and nationally people are aware of that. They don't know how much, so we need to help them understand how much. We will need support for this. So what we do need to do is pay attention and keep paying attention, because this is a big agenda, a big strategic agenda that will grow. I think that's probably enough for the moment, because the summary report captures a lot more of the detail.
Thank you, Alistair. Thank you, Gary. Great.
I think that the question we need to ask on this is this a priority, and are we really want to do it? Because if we do, and I do, I would suggest it reduces the shortlist of the new hospital scheme down to just one option, and that's new hospitals. And in this report, it's there at paragraph 32, new hospitals. Trying to patch up the existing hospitals will not work, I would suggest, if we want to keep down to net zero. I mean, you could get lift on gliders over the thermals coming out of RPH. And I suspect that Lancaster is the same. So what we've got to do, if we really want this, stop delaying the new hospitals and build new ones.
And Jeff?
Thanks, Chair. My question is not a concern about the report, which I welcome, and I'm a big fan of going to carbon zero, as some of you will know. But it's the focus on carbon when actually we need to be focused on pollutants as well. Now, they go hand in hand, don't they? Most things that produce carbon produce the pollutants, the noxious gases, the particulates, the nanoparticles that are in our atmosphere that damage health, both mental and physical, both acute and chronic, children and adults. It affects everybody. And so I'm taking the strategy to attack carbon levels as a surrogate for trying to tackle pollutants as other pollutants. But I think we need to do both personally. They're both big health hazards. Thank you.
Thank you. Well said, Jeff. Peter, please, and then Kevin.
Yeah, hi, thanks. I just had a look at the report, and as I was reading through it, I was just thinking to myself naturally, from my position as from primary care, thinking of the huge opportunity with the right incentives and the right policies in place, the huge opportunity that exists in the primary care and community sector. There's over 1,000 premises that the 4 pillars of primary care reach to, including optometry, dentists, GP surgeries, community pharmacies, all the associated vehicles that are used for business, so delivering medicines to housebound, and that's before you get to community care with the district nursing, health visiting teams, what have you. So you could take the route that there's a few small contracts with very big reach, but lots and lots of smaller ones with even if you only achieve a small measure of improvement, would have a quite a cumulatively a huge impact. So just to comment on that, and I think all members of the primary care team would be willing to support this in even a small way.
Thanks, Peter. Very helpful. Kevin, please.
Thanks, David. And notwithstanding the point that that Graham raised about the new hospital, which is a really important point, but just in terms of our normal capital, if I can put it that way, over the next decade, we're probably going to spend as a system close to or over $1 billion in terms of capital. And do we think we've got enough emphasis on how we use that capital so it's directed in the right way to help this agenda? Because that's an awful lot of good that we can do, and an awful lot of capital that we can use, which is in our own gift at the moment.
Yeah, absolutely. Thank you. And Dennis?
It's a really good report. Just a couple of quick points. I guess one of the things we've got to really start to consider is how we fundamentally reshape the culture of the way we go about providing services and the way we work. So, the substitution of analog technology for digital ones will impact, or should impact positively, on our carbon footprint. For example, the things that we've been talking about for many months. The opportunity to learn from remote working has had a significant impact on our carbon footprint just by people not driving up and down the M65 and various other motorways, etc. That's been a big impact. We shouldn't lose those wins. We should be thinking about what's the future model of working where we can use technology to make it more effective. We've got to consider, have we fully exploited the opportunities presented by digital technologies for providing care to our residents where it makes sense to provide it in that way? Not for everybody, obviously, but for a vast amount of people using digital technologies, it's better for them. It's better use of our efficiencies, and also it cuts down on carbon footprint. Now, if we were to do that and apply it to every single thing that we do in the system, then when we come to start talking about buildings for the future, and Kevin's point, buildings, you think of the carbon footprint that ensues from any new building, the use of concrete and all that sort of stuff. I'm no expert on it, but I think you get the general point. If we were to take a view of taking a radical approach to the way we use technologies, we'd probably find we need less fixed buildings or smaller ones, more efficient use of those buildings, different construction type, which would be a sustainable carbon footprint saving for all of us. So I think it's a really good start, but I would suggest or or humbly suggest that we also start to challenge ourselves on how serious we are at substituting digital technologies for analogue technologies as much as possible. Thanks, Chair.
Thank you, Dennis. So we take from this discussion, Gary and Alistair, that the shape and substance of the report is endorsed. There's a number of very good suggestions and offers of contribution that people have said in response to reading that, and this lands firmly in the in tray of the new ICB. And I think that the pointers that colleagues have given in the course of this discussion helps us think about how we take that forward, whether it be in day-to-day ways of working or the way in which we prioritise our big infrastructure investments. So thank you all very much. Gary, conscious this is your last meet, anything? This is the moment for anything you've always wanted to say but never really felt it was quite right. Anything you want to say, Gary, in conclusion before I move on?
No, I think it's all been said. But you know, yeah, perhaps the final point. If we deal with this, we are also dealing with mitigating the impact of climate change and other things, pollution and such like, on poorer populations. So that the whole point about improving health and avoiding the things that are coming down the line is as at the core of what the NHS is all about. So it shouldn't be sort of like a separate thing that we're doing. It's something that needs to be at the heart of everything we do going forwards. But it's hard to get your head around it at this stage. So hopefully the revised strategy at some stage in the future will talk to the way in which that can possibly happen.
Thank you, Gary. Well done. Thanks, Alistair. Right. New hospitals programme, Jerry, update, notwithstanding the fact that Councillor Gooch has just given you the answer. Can you update us on where we're at, please, in terms of progress?
Thank you, Chair. And I can only endorse his comments, although perhaps set it within the framework of the wider work that the new hospital programme is doing. When I came to the last ICB board, we presented the Q3 report, which talked very much about the process we were going through to produce a short list of options to take forward. As you will see from the report, that work has now concluded, and we now have a short list of options that include both new build and partial rebuild for both the two main hospital sites. You might think that is a very simple thing and an easy thing to reach, but it reflects a substantial amount of work going behind that, and perhaps also equally important, the reasons by which we have discounted some options. I'd have to stress at this point how important the level of engagement with the public, our staff and our stakeholders have been to bring us to a position where we have a now small but a very important list of options to take forward. We're now entering a period where we have to translate those options of new build or partial rebuild into very detailed descriptions. To do that, we are approaching this in 3 phases, which have a high degree of independency. Ultimately, we're looking to produce a business case by the end of the summer this year. And those 3 pieces of work bring together our system narrative and how the new hospital programme fits within our ambitions as an ICB. And it's worth obviously clearly reminding that the discussions we've just had around net carbon zero is an important interdependency for the new hospital programme, as is our developing hospital clinical strategy and our services for the future, and things like digital technologies and how they will influence the hospitals of the future. So our system wider narrative and the interdependency with the new hospital programme has a very important narrative that helps to promote and bring forward why the new hospital programme is so much part of delivering the ICB system deliverables for the future. We also have to produce now real detail around each of the options, including the service configurations, the numbers of beds that each option would incur, and perhaps equally important for the new build options, what are the available sites that a new build hospital could be considered to be built on. This work is now happening in great detail, along with developing that system narrative. The final part of the work that we're currently undertaking is continuing to work very closely with the national team for the new hospital programme, understanding the work that they are doing around what they call Hospital 1.0, which is looking at the design of hospitals for the future, working closely with them around our demand and capacity modelling. And 30th of June this year, I'm pleased to report that the national team will be coming to Lancashire and South Cumbria to visit the Preston and the Lancaster sites. We are hoping to complete this work, as I said, by late summer of this year, and I will be happy to come back to the ICB board, as Chair indicated, in the sort of period of July, to be able to give more detailed update on what the options are starting to look like in more detail. Thank you, Chair, and I'm happy to answer any questions.
Thank you. I mean, it's all very clear, and we can note the progress undertaken and note the activities for the next period. I'll take any particular points of clarification anyone wishes, but then we can move on. Okay. Thank you. Well done, Jerry. Our final item for today is Jackie's here to talk to us about West Lancashire and the shaping care together.
Thank you, Chair. Thank you. And I was really conscious when Jerry presented last time that when he came back here with his Q4 report that you heard about shaping care together. You know, we have done that. Jerry and I have both presented at the Lancashire OSC. And it was really clear there that they were pleased that they'd heard both together, and have invited us back to go back and talk about our progress there too at the same time. Obviously, we're not of the same scale as the new hospitals programme. We're a much smaller local scheme, but I think for me it's very important that this board hears what's happening with the West Lancs residents working alongside Southport and Formby, but really so that we can consider those short list of options that Jerry's just talked about with what might happen for our West Lancs residents. I think the paper sets out where we've got to and what we've done in terms of that statutory obligation to engage. We are now at the end of our listening phase. We have done all of that engagement, and I think we've done very well really to listen to our residents, patients, staff, stakeholders. We've got some great feedback, and we've really tried to make sure, Chair, that we have heard from the 9 protected groups that we've got the geographical spread across West Lancashire, Southport and Formby, and that's really been quite hard to make sure we've got that. There's no JSNA, there's no baseline data for us as a place, because we span the 2 ICB boundaries, and as a result we've had to construct that ourselves. Really, Chair, we've very much had public engagement involved in helping us construct the engagement that we've done. We wanted to make sure our residents were involved in that, and we have got representation from public health in both Lancashire and in Sefton, transport groups in both sides, and equalities impact is across both places. Really, because this is quite hard to handle, really, Chair, because it is across those 2 boundaries, and we wanted to make sure that we had got engagement. You've got in the report, I think you've got the themes that we've heard to date, and there has been some things in there that have surprised us, like the 70% of our residents that have responded to say that they're quite happy with telephone and video appointments. But one of the things I just wanted the board to understand is we will do a deeper dive into what we've heard here. Is that particular demographic profiles? Is it age profiles? Is it, geographic? So that actually we're not, as we consider and hear what our residents have told us, we understand whether that needs to be differentiated offer as we think about the options going forwards. So we have established a clinical and care congress similar to what you've just heard with Jerry. We are constructing a strategic model for care, and it will be there that we will take what we've heard in terms of our residents and come up with a shortlisted option. We're slightly behind the new hospitals programme in terms of our progress to date. But the next time we come back, Chair, we will have that short list of options for you to consider. The one thing I really wanted to come here to talk about was around that governance of the shortlisted options and how we take the decision going forward around what the preferred option might be and what it means for our residents. I think what we've heard this week is that Cheshire and Mersey ICS have been asked to commission an external review now of hospital services to look for a long-term optimum care model, is what's actually been quoted. So we need to understand going forward how Shaping Care Together will fit within the context of that, and what the governance and decision making are in terms of making, sort of taking this forwards. I suppose I wanted to assure the ICS board that we'll continue to work with Cheshire and Mersey, and we will come back here and with other partners to make sure that we get the quality of care that we want for our West Lancs residents. But we, sort of making sure that we've got the right decision making and governance structures around this. And so, Chair, that's really what I wanted to do, was just to get to have the board note the contents of that report and our continued engagement here.
Thank you, Jackie. It's a very clear report. Peter, is there anything you wish to add?
Yes, thanks, Chair. And first of all, thanks, Jackie, for that. It's concise and clear for the board. There's two reasons why I think this board needs to be close to the progress of Shaping Care Together. The first being that, as we've always said, one of the challenges of West Lancashire was that its acute traffic tended to head towards Cheshire and Merseyside, but the patients are Lancashire and South Cumbria residents. And if we follow the same ethos of the new hospitals programme, we've always talked about right-sizing the hospital infrastructure to make sure it's appropriate for the care. And if we do the same thing for Southport and Ormskirk, then we would like to see through new integrated clinical care pathways, far more people managed outside of that hospital infrastructure, which puts them into the infrastructure that sits within Lancashire South Cumbria. So it's important from you to remember that the community care that's going to be necessary, the integration with that, the integration with social care, all sits within Lancashire South Cumbria. So that's one important reason why this is relevant. The second, of course, is we don't quite know what the list of options will be, but we have to bear in mind that one of those hospital buildings sits in Ormskirk, which is within Lancashire South Cumbria. So just people need to be aware that one of the potential outcomes may be an additional potentially a hot site or an A&E within Lancashire South Cumbria. So just to flag that up as one of the potential outcomes, not preempting what will come out of the review.
Thank you, Peter. We've got Kevin and Graham and Trish. Just a bit of history. I welcome your perspective on this as well, please. Kevin.
Thanks, David, and I welcome the fact that Jackie's brought this today, and thank you for it. It's obvious and it's clear that we need to have the interrelationships between the two programmes of work, because depending on what is shortlisted and what goes to what's chosen on either pieces of work are going to affect patient flows both ways. So we need to understand that. We need to model that into our thinking, because it could have a material impact on size, capacity, beds, out-of-hospital services in both directions. So it's a really good piece of work, Jackie, and thanks to you and Jerry for making those links. It's really important.
Thanks, you, Kevin. Jerry. And Chair, if I could just come back there, obviously, I've met with 5 MPs across the whole of East Patch, and I'll echo Kevin. That's exactly what they're worried about for their residents, that there isn't a gap, whatever preferred options we all come up with. We make sure that we've got places that our residents can still access services. So it's really at the forefront of my mind as we're doing this.
Yes, I certainly look forward to it, because I've always seen that the West Lancashire question is a bit like the Schleswig-Holstein question, and that it's hard to find an answer to it. We have lived through that period of one hospital on 2 sites, one in Ormskirk in Lancashire and one in Sefton. And as you say, it looks largely towards Merseyside and Cheshire for other acute hospital needs. But I take Peter's point that it's looking at a system of community health without putting the acutes at the top of the pinnacle. And it starts with something in the community. So I very much look forward to seeing what comes out of their report and see what options they come up with.
Thanks, Graham. Trish, any thoughts you wish to add to the discussion?
So appropriate I say something. So for those that don't know, I was residing over Southport Normsgate hospitals, and it is extremely complex. It goes back to some decisions made way back in the 1990s from something called the Shield Report that actually put those two sites and the provisions the way they did, and there's been a complexity ever since then, really, about how to do that. The reason for Shaping Care Together coming together was for a programme was quite frankly, whatever the outcome will be, but there needs to be an outcome. There will be clearly certain sectors, individuals or whoever they may be, that may disagree with how that shapes up, but the most important thing that Shaping Care Together gives it is a structure that it has gone through a due process. And the most important thing when I was sitting on the side of Cheshire and Mersey overseeing Southport Normsgate was that we were very clear about potential unintended consequences into another system, and i.e. this system, because we have, make no doubt, whatever decisions are made, there are going to be, well, let's make them intended consequences instead of unintended, but it needs to be shaped and formed, seeing this through two lenses, really. So I wish I had the answer to this. I haven't, but I think the most important thing we can do is, number one, go through a due process, engagement, transparency, and secondly, just make sure that we link in with both systems to make sure we get the best outcomes for the residents that are being served. I think that's the most important thing. So, but I was a great believer, but I would be, of the Shaping Care Together, because it just makes sure the oversight is across both systems, and that's key to this.
Yeah. Thank you very much, everybody. Okay, so all well noted and all supported. Looking forward to working with this going forward. And the neatness of the agenda today is the connection now with the new hospital programme discussion is something I quite haven't appreciated until now. That's very helpful. Thank you, Jackie, and thank you, Peter. Right. With 2 items for information only that you can note. I've not been notified of any items of any other business for today, so that brings our business today to a close. Thank you again, everybody, for your contributions and consideration in this meeting and all previously. I thank you very much indeed, and very much look forward to working with you going forward. Thank you.